So we shall now go on to our last speaker, Dr. DEVYANI GADRE, who's a consultant cornea and anterior segment from GADRE Eye Care Center, Rajkot. And we have lovely memories, Dr. DEVYANI, of our arduous trip to Rajkot.
Chitra, what a trip it was.
Pandemic rush trip, yes.
Yeah.
Good evening.
Good evening, sir. Good evening.
We look at your video.
Yes. Thank you so much for the opportunity, ma'am. It's so nice to see you all. I'll share my screen now. I hope I'm audible now.
Can be tricky at times. It's not always the cataract that troubles you. This is a case of a perforated fungal keratitis which underwent therapeutic keratoplasty with us about a year back. When we planned cataract surgery for this patient, we realized it was a non-dilating pupil with what appeared to be an anterior subcapsular cataract. Here we are trying to dissect all the pupillary membranes, and by the time we dissected half of the membrane, we realized that it was a single membrane which could be removed in toto if we found the correct plane for it. Once we found the plane, it was actually a tug of war between me and the membrane and its thick adhesions underneath the pupillary margin. Finally, we were actually able to pull it out in toto, and thankfully for us and the patient, the anterior lens capsule was not damaged in the process of doing so. Once we got it out, we were actually able to get really good dilatation with the help of iris hooks. Here I'm trying to make a tear for the next challenge that we had, which was the rhexis. I believe in hindsight that this was not the right area to create the tear from. As you can see here, I have lost the flap, and now because of differential staining of the anterior lens capsule, I am actually tugging at an intact capsular bit, and in the process can create a radial tear which can lead to additional complications. When I finally realized that, I retrieved my cystitome yet again and went in and created a fresh opening in the anterior capsule, this time at a better area, because I was then able to create a flap, and the tensile strength and thickness, elasticity of the anterior lens capsule at this area from 2 o'clock till 6 o'clock was of much better predictability, and I was able to get a good rhexis margin there. And as we all know, rhexis is essential for a good outcome in these complicated cases. By this time I had reached the fibrotic band, and the fibrotic band was simply not budging. So we had to go in with the Vanna scissor and snip it apart. There's a lot of parallax here because the Vanna scissor that I had at hand was not angled, and therefore created a little bit of a blind procedure. Here I'm trying to retrieve the rhexis which was threatening to run away. And now that I'm back on track, I am yet again encountering the other part of the fibrotic capsule. This time, learning from experience, we decided to go in with scissors from the VR surgeon's kit, and this helped us get a clean cut of the fibrotic band. Here on forward, it was simply joining the dots and completing the rhexis. Rest of the cataract was uneventful, and the patient did well post-operatively. Few things that I have learned from this case are that we should always prepare a plan, wash the visco well before staining the anterior capsule, keep other instruments ready, and always have your fingers crossed. Thank you.
Thank you very much, DEVYANI. That was a wonderfully skilled surgery which you showed, and very impressive. More for the sake of discussion, we are going to be talking some now. Now, do you think, I'm all for an iris hook, and at the least opportunity, I would use an iris hook myself. But do you think in a post-PK case, maybe if a ring would have been a better choice, or do you differ? Because of course you could fashion out your side ports away from the graft host junction and do an equally good job, I'm sure. But do you have, being a cornea person, would you have any things to answer about that, Dr. Devyani?
Yes. So I have a couple of points. One thing is I completely agree. A ring would probably be more ergonomic and would avoid that many extra incisions into the cornea. I was lucky because it was a really large graft. It was a limbus to limbus graft that I was dealing with. So essentially, I was still in the graft. But the second point being that I personally feel whatever you're comfortable with, you should do it, especially in your most complicated cases. And so at this point, when I did the surgery, I was more comfortable with the iris hooks. And that is the only reason I decided to go for it.
Yeah.
And I was just lucky that it was a limbus to limbus graft.
How was your IOL power calculation done, the astigmatism part of it?
Yeah, so it was a fairly regular, again, because it was a large graft, it was a fairly regular central 3 millimeter zone, and we were actually able to get a decent keratometry. Because it was an anterior subcapsular cataract, we were not able to get it through our optical biometer, but with the A-scan biometry, we were able to get a fairly decent IOL power. And since it was a poor prognosis cataract surgery, honestly, I had already explained to the patient the requirement for possible refractive surprises at the end of the surgery.
This was a clear-cut case of a fibrotic capsule,
Yes.
but I'm sure Bharti would be better able to tell about, how beautifully Dr. Deepak differentiates the fibrotic capsule and a subcapsular plaque, wherein it seems, yes, if there's a yes, Bharti, would you want to tell something on that?
Yeah, ma'am. Actually, there is always a certain plane at certain points where there are weak zones of attachments between the anterior capsule plaque and the anterior capsule. When you are able to assess the cleavage, then you can get a plane of dissection and remove it. That is one point. Second is using a vitrectomy cutter. Using a vitrectomy cutter with low cutting rate, you can easily get a decent rhexis.
Yeah.
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 I think this was Dr. Bharti. I think this was a calcified subcapsular plaque.
Yes.
Rather than a fibrotic one.
Fibrotic, yeah.
Number one. And I think in these patients, we should try to create a smaller rhexis within the plaque and then try to dissect it 360 degrees.
Yeah.
The calcified subcapsular plaque, its adhesions with the anterior capsules. Once that is dissected, you can take out the calcified subcapsular plaque out and then create a normal rhexis.
Enlarge the rhexis, yeah.
Then enlarge the
Have
rhexis.
been
But
the way
it was a very the width of the calcified plaque was not that extensive. So that is something which would have led us to create a very small rhexis in the center, central to the adhesion of the calcified subcapsular plaque to the anterior capsule.
Because to make a rhexis in the plaque area is very difficult.
Yeah.
Not easy. So what I would have done is go beyond the rhexis, beyond the plaque, the plaque, and include the plaque in the rhexis within the rhexis area itself.
Dr. Mohan,
I would have used scissors there.
No, what you have to realize is that the calcified subcapsular plaque has adhesions to the anterior capsule.
Yes.
They are usually not in the central area. They are in the paracentral or in the mid-peripheral area. Not in the mid-peripheral, between paracentral and mid-peripheral. So you have to create a small rhexis right central to the adhesion of the calcified subcapsular plaque to the anterior capsule.
Yes.
If that adhesion is quite central, then you may go across. But if it is not right in the center, then you can create a small rhexis. Use a flat spatula by creating side port incisions, and then use the flat thin spatula to separate them. And once you are able to separate them 360 degrees, then it is. But usually you can create, if the calcified plaque is adherent in the not in the right in the center, maybe away from the 3.5 to 4 millimeter central area. Dr. Bharti, what is your take on it?
Whatever you said is correct, sir. Actually, the adhesions are there in the mid-peripheral area. But when you get a small central opening, there are certain weak areas of adhesions where you can get a cleavage and get using a spatula, get the membrane out. So whenever the adhesions are released, decent rexus is very much
Possible.
viable, possible.
Yeah.
Then second point I need to make is if the capsule is totally fibrotic, a vitrectomy cutter is a better option.
Absolutely.
Yes.
Absolutely correct.
Yes. So if it's a totally fibrotic without that subcapsular component plaque to it, then doing a vitrectomy cutter would have been
It's
a
less cutting rates. Yes.
yes.
Yes, scissors.
What would be the cutting rate, Bharati?
We would keep around 1,500.
Okay.
Very nice video, Dr. Devyani. I think
Thank you,
you
sir.
seem to have inherited your dad's surgical skills as well as his calm demeanor. Congratulations.
Thank you so much, sir. Thank you.
Very nicely done. Both Mohan as well as Rohit had very relevant points, but as I could make out in the video, this was a fibrotic plaque which was extending almost end to end. So either way, you could not have avoided you can't go beyond it, nor can you come within it. So obviously this was a pupil which was tied down, but this fibrotic capsules is one indication for me to use an LRCS platform. Because even though you don't get a free-floating rexus in these cases, it creates a nice template. And then you are able to, as you said, connect the dots and get a fairly decent centered rexus. Obviously, in that case, you could not have done it because the pupil was so small.
Very small, yes.
Extensive peripheral anterior posterior
You
syndicate.
have done it in this.
But that just makes me wonder whether this would be one of the indications for a Zepto, where you open up the capsule, where you open up the the pupil and then subsequently apply that to create a rexus.
So we did offer this option to the patient that after putting the hooks, we could do a Zeptorexis for him, but there was slight affordability issues, and these patients, I have seen all cornea patients are non-affording. So
All glaucoma patients are non-affordable. So you
And Rajkot has got the richest patients. Yeah.
I see. I don't seem to be getting them. That is for sure.
Anyway, I'm coming there to Rajkot on 24th April.
Oh, wonderful, sir. Great to know. Welcome.
But I think even if you get a can opener capsulotomy in these cases with multiple tags and with the soft cataract that you had, you could have got away with it. I mean, sometimes, these fibrotic capsules, you did a great job, but it's extremely difficult to get a round rexus. In these situations, I just go ahead and create multiple nicks all around so that there's no single area of weakness.
Yeah.
And again, you can go ahead and complete the surgery.
Dr. Vineet, would you have thought of doing anything in the post-op steroids, anything different you would think? How long would you use it, or would be just like a routine cataract surgery case?
All the fungal. Fungal.
Yeah.
Yeah, that's why I asked.
But but the graft looked pretty clear and quiet.
Yeah,
I mean, you can still start probably steroids slightly higher than what you start in routine cataract cases, and then probably step it down one or two steps, and then just maintain it at a higher dose. Because therapeutic grafts, first of all, what would be their inducible cell density at the time of cataract surgery, don't know. Plus, the grade of cataract was quite high. So much of pupil manipulation, pigment dispersion. So it's always good to, in such cases, like there is a chance of secondary endothelial decompensation. So steroids, you have to step up.
This patient was quite quiet. I was able to, as you've seen in the photograph, but I have had a couple of other cases, again, post-therapeutic keratoplasty cataracts, where you had to remove these membranes, and they do lead to greater AC inflammation. I've been lucky not to have endothelial decompensation, but that's just luck.
Do you do the endothelial?
Unfortunately, they're very hard.
Yeah. No, do you do a specular?
Yes, I do attempt it, but sometimes it's difficult to actually get a good capture, which is reliable.
How will a DSEC work in these cases in case the endothelium decompensates?
Yeah, so if we have a good keratometry, which is relatively decent in the sense that it's not too astigmatically bizarre, then a DSEC is a viable option for these patients, especially with these large grafts. It is possible, and good results have been seen. So I
So
personally
pretty
have
well,
had that is the next option if this patient's graph.
Did you use BSS plus in this case?
No, so I've gone ahead and done a standard BSS only. No BSS plus was used.
But logically, probably those are those finer points which
Yeah.
can be looked
Yes,
into,
next,
make it
yes,
more optimal.
I
and
agree.
yeah. So I think it's just that two of the presentations were not there. So I think we were able to have a much more extensive discussion. For that matter, I feel we discussed every case piecemeal, and there's a lot of take-home points for all of us. So I think I should conclude stating that it is the uniqueness of the expert panel and the kind of special set of speakers who put their life and soul and brought out such wonderful videos from their video album that made this webinar so unique and so different and so useful. In fact, I keep saying this sentence every time because that's how the kind of ARC webinars have been, and that these video bouquet just brings out the kind of talent. I'm not even sure when I take the name of those surgeons, some of them are so young and different, I'm not sure, but different presentations come across. So it's truly been a most learning period for me in my post as chairman ARC, and thanks to one and all of you. It's unfortunate that my co-moderator was not there, but I have my ARC there always backing me up. And my thanks are due to Mr. Kripal from AIOS team for all their support. My special thanks to Sai and Manjula who keep raiding your inboxes with all my ARC mails. I do hope it doesn't bother you. I hope you just understand it's just my efforts at getting education across to all of you. And my very special thanks to Anand Sethi, and thank you so much for spending your Sunday afternoon with us and making it so much easier for all our speakers and by meticulously sharing the videos. Thanks a lot, Dr. Anand. And finally, most importantly, special thanks to Entode for being superb sponsors and never a question asked. And all these years they have been consistently sponsoring all my programs. Of course, Sun Pharma takes care of the PG program in the last year. And finally, and most importantly, I think I owe my thanks to all the attendees who watched these ARC webinars. And believe me, it's those numbers which eggs me on to keep coming back to you every single month and every single week with more and more webinars. Thank you very much, one and all of you. Thank you.
Thank you.
Thank you.
Thanks a lot, madam. Thanks a lot.
Thank you, Rajan sir.
Thank you.
Thanks
a lot.
Thank you, Prakash sir.
Thanks, Chitra.
Thank you,
Thank you.
sir.
Thank you, Mohan. Thank you,
Thank you,
Rohit. Thank you, Dr.
Your boundless,
Thank you,
boundless
Chitra. Thanks a lot.
enthusiasm, motivation.